I think we'll go ahead and get started. Thanks to everybody for joining our webinar today. This is the October Becoming Baby Friendly in Oklahoma webinar, and I'm going to be talking about some of the recent changes to the Baby Friendly USA guidelines, and to reassure everybody, they're not like massive or major changes. A number of them are really kind of clarifications in the guidelines. So, and we'll go into that in a little more detail, of course, and then a bit more about the redesignation process. So, those of you that are already designated will be familiar with that to some degree, and will know what to expect. Anyway, so there's my disclosure, of course. No financial interest or commercial interest involved in this, part of our state project. And our key objectives today is to describe the key changes found in the revisions to the 2016 guidelines. Those just came out in July. And then to describe the baby-friendly redesignation process. Now, I will have Kyra after this webinar. If you haven't seen the Baby-Friendly USA send out a summary of the guidelines, and we'll make sure that we send that out to everybody again if you haven't seen that, and that's, so you'll have another written documentation of what we've covered today in addition to the slides and the recording and so forth. So just to kind of take a step back and once again kind of look at baby-friendly and the evidence behind baby-friendly. This was a nice summary that was in the Journal of Human Lactation a few years ago, and just some key messages, of what we have learned after 20 years of baby-friendly being implemented worldwide by the World Health Organization and UNICEF, is that breastfeeding does save lives, that if we really, the work that y'all do in the hospitals to help get breastfeeding off on the right foot really can have long-term effects on how long that mother and baby are going to continue breastfeeding. So definitely the hospital practices and hospital care has an impact. Wrong practices are still happening, such as separating mothers and babies, and inadequate staff training. We'll certainly touch on that some too. And baby-friendly is certainly most sustainable when the facilities continue monitoring the practices and doing those chart audits. And certainly a goal here in the United States that it's certainly definitely going to be most successful and most sustainable when it really becomes part of the hospital accreditation system and is really looked at as best practice and quality improvement, and not just an optional jazzy designation. So let's jump right into, before we kind of go into the guidelines revisions, to the recent controversy. So if y'all did not see the two commentaries that were published in the Journal of the American Medical Association's Pediatrics version, there were two articles, commentaries really, and Ingrid, was that August? They've just come out in the past 4 to 6 weeks. And anyway, so there was one commentary that was written by Dr. Joan Meek, who I know quite well and has been president of the U.S. Breastfeeding Committee, and talking about, implementing the 10 steps and some of the evidence and so forth. And then the other article, the other commentary, written by 3 physicians from the Massachusetts area, was very negative about baby-friendly and talking about that it's unsafe and about, babies having, neonatal collapse and skin-to-skin care. So just to let y'all know that that's out there and that's circulating, and you may have already kind of gotten some comments and questions from your staff or your physicians about that. And there is a response, so you can go on the Baby-Friendly USA homepage, and that's the link right there. But there is a response that's been publicly presented by Baby-Friendly USA, and they have also, along with numerous other professional, nationally active organizations and physicians, written letters to the editor of the JAMA Peds Journal as well. So we'll hopefully see some of those get published. But a few comments out of the Baby-Friendly USA Oh, hold on just a second. So Susie's asking about the number to call in. If those of you that need to call in by phone to get audio, the call-in number was in the calendar invite. I've been sending them to make sure people can find that. Anyway, so some of the comments that I've just pulled out, and the title of the more negative commentary was the unintended consequences of current breastfeeding initiatives. But they, Baby Friendly USA is in their response to saying that they had a number of comments in there that were not supported by research. They were very opinionated comments. And to reiterate, Baby Friendly is always is stressing safety. That we don't abandon or ignore our, hospital safety protocols. So patient monitoring, newborn monitoring is always important. So my example of a newborn sleep place is not a safe place, obviously. So though it does look very warm and cuddly. Anyway, and then right about the same time that those came out, the American Academy of Pediatrics SIDS Task Force and their Committee on Fetus and the Newborn came out with their wonderful publication on safe sleep and skin-to-skin care. So there, if you want a current evidence-based document to go to guide what that safe practice should be, then there it is. And it gives you good advice and good ways to kind of review your policies and protocols to make sure that we're practicing skin-to-skin care and rooming in a safe way. And one of the lead authors on that was Lori Feldman Winters, who was actually here 2 years ago and spoke at one of our summits. So some of you would have heard her. And so a few other comments from Baby Friendly USA, just to reiterate, in response to the negativity in the one commentary that Baby Friendly is not about making mothers breastfeed, but it's being responsive and making sure that she's making informed decisions, not that we're deciding for her and assuming she doesn't want to breastfeed or she's making a decision without enough information. It's all about informed choice. It's not about making a mother feel guilty. It's about, and I really liked this, preventing her regret for decisions made without the proper information. Baby-friendly policies protect the mother from the influences of commercial interest, and it obviously can and still does represent a significant culture change for most institutions. So we know this is not easy to change all these cultures overnight and have everybody on the same page. And that's where of course, the staff training piece is really, really important. Okay, so having said all that, let's move on and look at the changes or the tweaks in the guidelines. And here's where we are. Actually, this was as of 10/10. I forgot to change that on the slide, but we currently have 378 of our 3,200 roughly birthing hospitals that are currently designated as baby friendly, and we're now up to 18.7% of births that are occurring in a baby-friendly facility. So we may be on track to hit 20% by the end of 2016, which would be pretty exciting. Okay, so let's take a look at the new guidelines. These are on the Baby Friendly USA website, and once again, they sent a summary out. So just to kind of review some of the terminology as we look through this guideline, when they talk about the guidelines versus the evaluation criteria. So there's the guideline, which is like the 10 Commandments, if you will. We want to strive towards this, strive to achieve for all patients. But the criteria, of course, is what you hear me call the minimum bar, the minimum standard that must be achieved when you're being assessed. And so no one expects 100% compliance, or that every single patient, but you should always strive to achieve 100%, knowing that that's not always going to be possible. So some of the language that you'll see throughout the guidelines and evaluation criteria will say the guideline states all mothers. So once again we want to strive to achieve that 100%, while the criteria for being assessed, for being evaluated, will say 80% will report. So there's your 80% minimum bar. But once again, always strive to achieve 100%. So this is just to kind of give you a picture of the document that they sent out that summarizes the changes. And one of the things, I'm going to see if I can be really fancy here. I think this is what I want. Some of the things they did were just rearranging. So they had a preamble to the old guidelines, and they moved these 8 principles to kind of weave them in to the actual, as you're going through all the 10 steps and the bullet points under each of the steps. So they placed all those into the body of the guidelines and evaluation criteria. So that's kind of one formatting change, if you will. And then they added these 3 additional fundamental principles to the original 8 principles. And I'm going to go through those a little bit more. So just to also reassure people that are, well on their baby-friendly journey, or even, ready to be assessed or scheduled for assessment, that you do not have to come into compliance with these guidelines changes right now. Anyone who's going to be assessed in the next 2 years will still be assessed under the current, or the old 2010 guidelines. But so for this, you must come into compliance. Wait, I want to turn this thing off. I wonder how I turn that off now. Let's do that again. Anyway, so you have to come into compliance by October 31st, 2018. So anyone who's being assessed after this date, after October 31st, 2018, so roughly 2 years from now, will be assessed using these guidelines, the 2016 guidelines and evaluation criteria. So I asked, and if somebody wanted to be assessed in the next 2 years under the new guidelines, I went ahead and asked Trish McEnroe, who's the executive director, and she clarified that any assessments taking place between now and October 2018 will be done using the 2010 guidelines. Even if you would like to be assessed under the new criteria, they have made the decision not to do so, because that's going to cause public confusion. If you have hospitals that were assessed in the same time frame, but they were held to different standards. So once again, just to clarify that, be aware of these, and if, depending on when your facility is going to be designated as to whether, you want to put all these into practice. And hopefully, you'll find that there's not huge changes, but there are some key ones. Anyway, so the new fundamental principles that they added, here's one: healthcare delivery environment should be neither restrictive nor punitive. And the goal, of course, is to facilitate that informed choice on the part of the mother and her family. And the healthcare environment should be sensitive to cultural and social diversity. So a couple of the new key tenets. And that the mother and her family should be protected from false or misleading product promotion and or advertising. So that's, of course, that commercial piece. And, well, I thought there were 3. I think that one of those was combined. Anyway, and then, of course, follow your safety protocols. It's, you implement the baby-friendly guidelines, and you follow your safety protocols. So make sure your implementation is consistent with that. Oh, excuse me. Let me back up. So those were existing ones that they were just reiterating, and then here's the 3 new ones that they added. That comprehensive policies, so making sure your policies, really cover all of the practices that they need to, so that your staff can do a good job in providing that evidence-based care. Well-trained staff, here we go again. Make sure the staff training is adequate and effective. And then, of course, monitoring of practice. So those are the 3 new ones there. I'm just going to check and see. And as we go through, you can certainly, oh good, you're kind of responding if you see chat, Ingrid. if y'all have questions as we go along, you can certainly put those in the chat box, and we can try to address some of those towards the end. Let me get you out of the way now. Excuse me. Okay. Okay. So let's dive into the actual changes. There was one really minor change on step 1, which has to do with the policy, but also the posting or the display of the 10 steps. So they revised the language about the required postings to read. And I'm trying to kind of provide you the actual information without, being boring and just reading all of this text. So I've tried to really highlight the key points. But that they want to make sure that when you display the 10 steps, and many of you know this already, but to reiterate that that includes a statement that talks about the compliance with the World Health Organization Code of Marketing, and that those should be prominently displayed so that your 10 steps are displayed in the appropriate area. So here's a couple of examples, one from Integris Baptist and one from OU Medical Center. So we've got the exact language of the 10 steps, and then see, I don't have a mouse now. Why don't I have a mouse? Because I've do that. Maybe I can do, yeah, you can see it. Can y'all see my little red mouse now? Okay. So, Integris Baptist has, the language actually in a couple of places about the WHO code, and OU has it down here near the bottom. So just to be sure that that language is included. So step 2, this gets into staff training. So there'll be some really, I hope y'all will be pleased with some of this, but they've actually added a description of the required content for healthcare providers to be a little more informative on that. And so at a minimum, all healthcare providers that are going to be interacting, with mothers and babies, mothers and newborns, should have a true understanding of exclusive breastfeeding, what's important about exclusive breastfeeding, physiology of lactation, how their specific field of practice impacts lactation. So whether they're an OB provider or a pediatric provider, for example, and we'll get into even other healthcare providers that may be involved. And then how to find out about safe medications for use during lactation. So making sure that the providers who are the ones that are going to be making those recommendations. Now here's a piece that I think y'all will be very excited about. If healthcare providers do not teach specific skills, it is not expected that they be able to describe or demonstrate them, but they do have to know to whom to refer a mother. So in 2 years, if you're being assessed after October 2018, your physicians who might be interviewed, such as your OBs and pediatricians, would not be expected to demonstrate, for example, hand expression if they do not actually teach that in any setting. So I think that's one piece that will be exciting, but they have to know who is going to teach that to the mother, and to know that that's happening, and maybe that that's happening before discharge, so they should know about it. So another piece of this is giving examples of training for staff, say, outside of your maternity services. So for example, just to give you, they had several, but just to give you a few, your pharmacist. Everybody should understand the importance of exclusive breastfeeding, but your pharmacist also needs more knowledge about medications and where to go to find that information. Your social worker, for example, should know the importance of exclusive breastfeeding, but what are community resources? Where are you going to refer mothers for skilled support? Your anesthesiologist should know about exclusive breastfeeding, but also why is immediate skin-to-skin contact important? So what's going to be in their practice realm? And then they clarified a bit on the assessment of healthcare provider knowledge. So just to make sure that of healthcare providers with privileges. So if they're going to be interviewing OB providers, pediatric or family medicine providers, it's not just, and I think this is what has been happening when they do assessments, but it wasn't maybe clearly stated in the guidelines. So just to clarify that if it's someone who has privileges at your facility, then they're fair game to be interviewed by the assessor. And so there's the 80% bar that's going to apply to them. I hope that makes sense to everybody. So I think if some of these changes or clarifications, obviously they're doing because they've gotten a lot of emails and questions about this. So let's just get this in the guidelines. Okay, step 3 is, of course, prenatal education, and really just some kind of minor changes here, but I think important ones. And so to really clarify that facilities should either foster the development of that prenatal breastfeeding education component or coordinate services with programs that are providing it. But you're still responsible to make sure that most of your mothers delivering there have had access to that quality prenatal education. So it's really stressing and encouraging building those relationships with community-based programs. For example, if a high percentage of your patients are enrolled in the WIC program, and then making sure that you know what WIC is providing to them, and that they're getting prenatal education, and that they're getting the appropriate messaging. Or in your community, if there's some other organization that's doing some sort of prenatal education, to make sure that it's consistent messaging, that they're going to also be talking about the importance of skin-to-skin contact and rooming in and exclusive breastfeeding. And that can count as some of your effort to ensure prenatal education has been addressed. So, all right, so step 5, and of course you can see we've skipped, we don't have changes to all of the steps, or about half of the steps that they had some tweaks or clarifications or kind of significant change. So step 5 is they revised the language about initiating milk expression when mothers and babies are separated for medical reasons. So this is wordy, but just to really stress that milk expression should begin as soon as possible when we know the baby is being sent to the NICU or being shipped out to another facility, but no later than 6 hours after birth. So we have within that first 6 hours to really stress some form of milk expression should be happening, not necessarily bringing in the hospital grade pump. And that's what I underlined there at the beginning, that it's particularly recommended to begin that manual expression within 1 hour, or even that can be your main form of milk expression over the first several hours. So that, once again, the pump doesn't have to be wheeled into the room immediately, but at least get the mother started doing some form of hand expression ASAP. So that's really the step 5 change. Step 6, it was not a huge change, other than that they removed language that referenced the Joint Commission's core measure set, looking at who's eligible, or kind of maybe your contraindications to a mother breastfeeding or exclusively breastfeeding. And part of the reason for that was, let me see if I can do this again, because the Joint Commission is an outside organization and they have their documents and guidelines, and they make changes. And so Baby Friendly was rapidly realizing that they're referring to something that's can be changed or become outdated, and they don't want to see that. And of course, those of you that are accredited by Joint Commission will know that their perinatal core measure on exclusive breast milk feeding, considering the mother's intent or initial feeding plan, they've dropped that one because it was very difficult to really adequately monitor that. So there were a lot of problems with that. So they've really dropped that PCO5A and just left with PCO5. So basically what Baby Friendly USA is saying is that they're not going to refer to Joint Commission, at least in setting those, go back, in defining that. It would be whatever the current medical recommendations are, for example, from the AAP or ACOG or something. Step 9 is, of course, our artificial nipples. So they revised to clarify that as they're assessing your breastfeeding couplets, that once again that 80% bar, that of your infants who are breastfeeding, 80% should not be using bottles. Not necessarily that they're 80% exclusive breastfeeding rate, but if babies are being supplemented, that they're not using bottles. So some alternative method should be offered if supplements are happening for whatever reason, medical or maternal choice. And the other rationale is that if you're really providing that excellent patient-centered education, then you should be able to achieve that at least 80%, are utilizing those alternative feeding methods. So, so that's step 9. And then, a couple of changes or revisions or clarifications in the appendices. So Appendix B had a section on specific medical reasons for supplementation. And once again, they were concerned about things getting outdated before, and not wanting to change the guidelines every year. So, so now what they're saying is facilities should develop, their own protocol that describes current evidence-based medical indications for supplementation, and really clarifying that yes, you can use the protocol from the Academy of Breastfeeding Medicine or WHO or something, as long as it's a national or international authority on the subject that you can cite as your reference or your medical recommendation for your protocol on supplementing. That hopefully makes sense to everybody. And so just once again that the facility is responsible to ensure that those protocols, are updated and maintained by current evidence. So, all right. So let's say you actually get assessed and get designated, and those of you that are on the call today that have gotten to this point, it's not the end of the road. You may look like our poor critter here in the picture, but things don't stop, and now we don't have to do this anymore because we got designated. There's still work to be done. It's the maintenance or the sustainability of all this hard work. So let's look at what's involved in the post-designation process. So just for those of you that haven't gotten to this point, you'll know what to look forward to and actually be hopefully excited about, and it won't be as hard as what you're going through initially. But designation does last for 5 years, and starting next year in 2017, the redesignation process at 5 years will be done through an on-site assessment. They've been working on this for a number of years. So you'll have some, and I'll go through this in a little more detail. So currently in Oklahoma, this won't impact anybody next year because we didn't have any hospitals designated in 2012. Our first hospital that was designated in Oklahoma was Claremore Indian in 2013. So everyone will kind of fall under this new redesignation process. But monitoring, of course, keeping tabs on what's happening, stay vigilant in the meantime, and don't let your practices, slide. Keep auditing, so kind of develop a process that those routine audits can be happening. And once again, it's easier to maintain a practice that you've implemented than to fix one that you've let backslide. And maintain your task force. And obviously, y'all, as you're working on this and you have task forces, you may have task forces that are meeting fairly frequently as you get closer to assessment, and you certainly don't have to maintain that level of frequency, but have some kind of regular task force meetings or communication to make sure that your policy and training and procedures are all being sustained, and that things aren't slipping. So so a little bit more detail on Baby Friendly USA's post-designation process. In that 5-year period of time, you'll be assigned QI projects on specific steps each year you know, a couple of the steps, I believe. And so in the first 3 years, it's that, you know, QI projects and sending in documentation or some kind of report to Baby Friendly USA. And then the last couple of years of that 5-year span is really, it's really like your kind of back-end dissemination and designation phases, but not quite so intense because you're not starting, you know, from scratch, and really just making sure that all your ducks are in a row, and that you'll be ready for that on-site assessment. The steps are assigned by Baby Friendly USA each year for your QI reporting, and there are tools that you'll find on the portal that they will direct you to as well, so that you'll use to report. And of course, money. There's an annual fee to Baby Friendly USA to maintain that. So, so once again, on-site assessments. If your designation is expiring in 2017, then they would be scheduling you for an on-site assessment, but we don't have any facilities that applies to. And their goal is that in that 5-year period of time, you will have really, through those QI assignments, have audited all the 10 steps. So you should be, you know, really up to speed and ready for a reassessment. So, and asking, you know, what's involved in that to the on-site assessment. The reassessment will be almost exactly like your initial assessment. They'll still schedule a day and a half and plan to do, you know, the big leadership meeting, patient interviews, staff provider interviews, and, you know, review all your education and materials and so forth. They'll want to see the formula on voices, and so pretty much all the same steps that you would experience on your initial assessment. So, okay, so, and another question I asked, what if you don't pass that reassessment for some reason? No worries, and this is very similar to what happens on your initial assessment. And for those of you that haven't gone through the initial assessment, the Baby Friendly USA contracts with different skilled clinicians who will come out to do the on-site assessment. They'll be the ones that come in person and interview everybody. And they will, they're really kind of collecting the data, and that will be sent to the external review board, and it's all de-identified. So the external review board doesn't know what hospital, what state, names of anybody, you know, that works there. They'll have facility data, you know, how large a facility, and, you know, how many staff and physicians and insurance, you know, and the percentage of Medicaid, and, you know, some demographics like that. But they won't know the name of the facility, so it's definitely very, they're very careful to make sure that every hospital has a fair assessment. But if you, for some reason, don't initially pass, and they may tell you there's a couple of sub-steps that need work, hopefully not major steps that need work, and they will recommend some improvements, and this can entail either a QI project, which a couple of our hospitals have gone through, so it's kind of like you're almost past, just do a couple more things, and then, you know, you won't have to have another visit. Or it might be, you know, serious enough steps that they feel that you need to develop an action plan and then schedule actually a return on-site assessment. Usually that's a shorter one where they'll come out and just evaluate on the pieces that you did not pass the first time around. This is what happened at OU. So anybody who wants to know about that, I can tell you in more detail. And then of course they would review either your QI reports that you've submitted or the revisit assessment, and hopefully tell you that you've passed. So I am going to kind of pause here and see if we have any questions from anybody that's on. We have a few other announcements and things to share too, but I wanted to kind of pause and see, and feel free to take yourself off mute if you have any particular questions, or you can type something in the chat box. So I will stop talking. Ingrid, can you think of anything that might come up? Helpful question.
Well, so a question I might have is if somebody were thinking of, if somebody's just starting on this process, what guidelines would you recommend they adhere to? Because if they decide that they want to start now
and
then have an assessment before October of 2018, what's the standard?
That's a great question. So for those of you that might not have heard, Ingrid was asking, so if a hospital is just now getting started, what guidelines would they follow? It's really going to depend on your predicted timeline of when you think you'll be ready for assessment. So if you're literally just getting started, just joining our Becoming Baby Friendly in Oklahoma project, or thinking about it, in January, then if you really feel you would be ready for assessment by October 31st, 2018, you would follow these new, the revised guidelines. You would follow the 2010 guidelines. Yeah, you could hit me if I say something backwards. However, most hospitals, it usually takes them more than 2 years to really work through all of the processes and make all of the practice changes in the staff education and get all of that hardwired. So I would venture to say that most hospitals that are just getting started now are going to be assessed after October 2018 and would want to utilize the revised guidelines as they're implementing the steps and looking at your staff and provider training. So that's a great question.
Well, let's say they use the new guidelines and then they rocket ahead and are really ready before the new guidelines go into effect. They're still going to meet the old criteria if they're following the 2016 guidelines, or...
So if someone started right now and really moved a lot faster, I think most of us would want to know how they did that.
I'm just trying to cover all the bases here.
I know. And if somehow they thought they were ready for assessment sooner rather than later, would they meet, the one piece probably that jumps out at me is the provider education piece, that if you're going to be assessed in the next 2 years, your providers do need to be able to demonstrate hand expression and position and latch, which is what's been happening currently on assessments. We have to have the doll in the breast, and they have to kind of show you, how to hold the baby for the right position, and they have to literally demonstrate hand expression with the breast model. So that's probably the key piece that jumps out at me that you would need to be prepared for. And otherwise, most of the changes would be, you'd be ready. So that's also a good question.
So if we have some real go-getters out there, that's the only thing I would focus on.
And if anybody moves through in that fast time frame, the rest of us want to know what they did.
Yeah, we need to come give us some
we'll get you to give a webinar on how to implement this so fast. So, well, I'm not... Oh, yes, go ahead.
This is Bill at Canadian Valley. A quick question about that topic, about the physicians. Is that OB and pediatric physicians that they will expect to know how to teach or demonstrate hand expression and pump usage?
Yes.
Okay, great. Thank you.
In the next 2 years, that's still the current expectation. Or family medicine, if you have a family medicine. So anyone else? Well, we have a few more slides just to kind of give you some announcements and some other news. And if somebody does think of another question, feel free to either stop me or put something in the chat box, and we'll certainly take questions after the webinar as well. So and let's see if I can move on here. Okay, so just to also reiterate, first off, at the bottom, everyone who's on today will get an online evaluation. So please complete that. It's pretty short, and just give us some feedback on what's been helpful on a particular topic, and certainly any input on future topics that you would like to see addressed. So definitely give us feedback on that. And otherwise, we have our last 2 webinars of the year we're very excited about. We have the November webinar on supporting Hispanic breastfeeding families. I know that's one we get asked about a lot when we're doing trainings. And Regina Roig Romero is a Cuban, and actually is, I've forgotten her exact title now, but she's a director or something in the Miami, Florida WIC program. So certainly in a state with a very high Hispanic population, and she's of Cuban, her parents were Cuban immigrants, and she's bilingual and well-versed to address this topic. So we're very excited to have her. And then in December, those of you who were at the summit 3 years ago, when did we have Clifton? I think it might have been 3 years ago. And everyone really loved having Clifton Keenan as our keynote speaker, and we've twisted his arm to do a webinar for us in December before his new baby comes. So you can keep him in your thoughts and prayers, as he and his wife are expecting their first baby in about January. But anyway, he's going to talk about getting buy-in from the community, which, you know, for many of us will also kind of help address the healthcare community too, if we're still struggling in that area. So we'll be looking forward to that. A new resource that we've just completed development of, and many thanks to Kyra Walker, our wonderful administrative support person. She did a lot of work to pull this one together for us, but this is a new one-pager that we have on skin-to-skin contact, and also kind of briefly addressing rooming in and feeding your baby, meaning, you know, exclusive breastfeeding and avoiding pacifier. So kind of addresses some of those key baby-friendly points that we want mothers to be able to understand before they come to the hospital, and also understand, you know, in the hospital, why is this happening, and some of the questions that they might, you know, be asked by the assessors. So these are designed to be used, you know, in whatever way helps your facility. They can be utilized for prenatal education. They can be, you know, included in postpartum information as well, and it's translated into Spanish. So it will come as a one-pager that's bilingual, English on one side and Spanish on the other. And those are posted. It's posted on the OBRC website, which I can actually show you real. No, I don't want to do that. Go away. How do I get out of here? This card. Whoops. There we go. I'll go to just show you real quick on the website, for those of you that may not have looked, where we have patient materials. So this is our home page, baby-friendly webinars and things you can always go back and look for, but patient materials. All right. We're circling the wagons right now. Anyway, all of these are available that you can either print them out, and if your facility has good, you know, printing capabilities and you want to print in-house, make use of them. And smaller facilities that may not be able to, you can certainly order these online. We just charge the printing cost. And so the skin-to-skin one is on here, but not in the little picture thing. It's right there. So anyway, go back here. So we're excited for that new handout. And then just to reiterate, those of you that, you know, may not be aware that we did complete development of the online breastfeeding training for healthcare staff. So that's the 15-hour online didactic course that meets the Baby Friendly USA requirements for the staff education. So just the didactic piece, not the clinical skills piece. And if your hospital is currently enrolled in BBFOK, it's $30 per staff person to get them enrolled in this through the University of Oklahoma Health Science Center online learning portal. And then they have up to a year, right? They have up to a year to complete it, though of course you would encourage them to complete it in a much shorter time frame, and that they can work through this, you know, in phases and at work or at home. And at hospitals that are not currently enrolled, it's $60 per person. And if someone in your facility wants to preview the course, just contact us and we can give you know, a manager, educator, someone of that nature a trial access to take a look at it. So, and you can, of course, check that out online too to see what that looks like. And then last but not least, I think that's my last, yeah. Last but not least is just a reminder of our 5th annual summit. It's hard to believe number 5 is coming up in February, but it's Friday, February 24th here at the Samus Education Center, which many of you have been to. And we're very excited about our speakers this year. Melissa Bartik is a physician from Massachusetts, and you've probably heard us cite her in numerous ways, but she's been very active in the Massachusetts Breastfeeding Coalition and very active nationally. And she's key author on some of the significant publications about the cost to the healthcare system when we talk about the $13 billion in additional cost are saved and 900 infant lives. She was the lead author on that. And they just did a revision of both the infant and maternal and kind of combined that into one article that just came out this month. So she will actually be sharing in one of her presentations some of the data on that. She'll also talk about lessons learned from their state collaborative in helping hospitals with baby-friendly and some diversity and social marketing information as well. And then Cynthia Good-Mojab is a licensed mental health counselor and also IDCLC, and has done a lot of work on the effective counseling skills, of course, but also the kind of equity and healthcare disparities and how to address that in the breastfeeding arena, if you will. So a new element for the summit this year for hospitals that are sending teams or staff is in previous years we've funded a travel stipend, and so in kind of consultation with the health department and looking at maybe something that would be more useful for our hospitals, and now with the online curriculum available, that it will actually be an education stipend. So if you are enrolled in Becoming Baby Friendly in Oklahoma, meaning we've got your CEO letters at least, and you're up to date on requirements such as submitting, you know, the data and surveys and so forth, that you'll be eligible to enroll up to 8 staff in the online training, that cost would be covered. And if you're not a participating hospital, that you're just eager for more staff education, you can enroll up to 4 staff after attending the summit as well. So more details on that, of course, are available online on our website, so you can always take a look there. Well, that is really all that I had to share today. Does anyone, any other questions or any other announcements from anyone that's on the phone? It's quiet out there in the cyberland.
This is Angela at Sampson. I'm not even really sure if we know what we need all the time.
Very true, Angela. I understand.
That's why we're so quiet.
That's okay. So, well, hopefully this was helpful. Not a real jazzy subject, but I thought it was important to get this information out to everybody as soon as possible, so that you are aware of what some of those changes were. And once again, we will send the summary from Baby Friendly USA. Kyra will send the link to the recording and slides and so forth as well, so you'll have all that in an email. And please give us feedback on the webinar evaluations. So having said all that, I'll give one more opportunity if anybody else has any questions. And let's see. Oh, and one comment from someone is be sure to remember to sign your CEO letter. So we'll and get that sent in. So because we want you to, if you think you're enrolled but not sure, you can always contact us as well. I know we had one hospital that we couldn't we somehow never received their CEO letter. So definitely we want you to be eligible to get the online training. So just, yeah, let us know what we can do to help with that. So, all right. I am not seeing any other questions. So we will actually end early. I know y'all won't complain about that. And we hope to see you online for Regina's talk in November, and enjoy our fall weather. So talk to everybody soon. Bye-bye.